Welcome to Flare Capital's quarterly expert roundtable webinar series. This time, we're going to be focused on behavioral health, access, quality, and specialization. This is the 7th event in our series following earlier sessions where we've covered fundraising, diversity, equity, and inclusion, go-to-market strategies, building world-class teams, product market fit, and virtual specialties. Today, we're going to be spending time with an amazing group of behavioral health tech founders and executives. But before we dive in, I want to set the stage with a little bit of background on the fundraising landscape. So we have a long history in this country of treating mental health conditions separately from other medical care. Unfortunately, we stigmatize patients, and we also criminalize patients, which was tragically a hallmark of the opioid epidemic and many other behavioral health conditions. COVID only made that worse. I think it left people's thoughts a little bit during the COVID crisis, but increased isolation, fear, logistical challenges, et cetera, only made things more difficult. On the bright side, it also opened the door to new ways to access care and inspired a new generation of founders who have made it their life's work to improve care for these patients. So looking at this chart that we have here, this is actually Rock Health data. It's funding that has gone into behavioral health tech companies over the past 5 or 10 years plus. The last 5 years has been a particular focus of innovation and funding. As you can see, 2021 was a huge year for the category, bringing in well over $5 billion in capital. We've seen numbers as high as $5.6 billion. And to put this in perspective, that is larger than the next 2 clinical conditions combined. So that's diabetes and cardiovascular care. Much of this capital went to a number of kind of later stage platforms and companies that are starting to scale nationally, which is a really good thing to see. I mean, you can see that in the average deal size as well. You know, what started off as average deals in this category being $10, $15 million per deal are now closer to $50 million per deal. And it's not just going to late stage companies. There are a lot of brand new startups that are focusing on individual patient populations and clinical conditions. So that's also great to see. And we're going to be spending some more time talking about that specifically later. I will mention, so Q1 of 2022 did show a bit of a step back from this time last year. It's a little hard to say that because 2021 was such an anomaly in terms of the amount of spending that went into the category, but it's about 40% lower than in Q1 of 2021. And behavioral health tech is actually still the leading clinical condition. Cardiovascular care and diabetes, for example, still add up to less than the total amount that went into the behavioral health tech landscape, that $1 billion mark in 2022. So everything is a little bit down. And as we see the data come out for Q2 2022, when the macro trends that we're all living and experiencing now, we expect that trend to continue. So today, we're really fortunate to be joined by 10 outstanding entrepreneurs and executives. We've organized this conversation into 4 sections. So the first conversation is going to be a one-on-one fireside chat with Dr. Gary Gottlieb. He's going to talk a little bit about how we got here in the first place and where he believes the biggest areas of improvement can be. Then we're going to transition into a series of panels. So the first one is going to be with Sandra Malik, CEO and co-founder of Firsthand, Sandra Kuhn, head of commercial enablement at Headspace Health, and Dr. Taft Parsons, Enterprise Medical Director of Behavioral Health at Humana. And we're going to talk about access to care, quality, the transition to measuring outcomes. Then we're going to shift into a conversation specifically about young people. Arguably have the 3 leading health tech founders focused on designing solutions for kids on the panel today. Naomi, CEO and co-founder of Brightline, Nikki Tesler, co-founder and CEO of Me Health, and Lynn Hamilton, co-founder and CEO of Vita Health. And then lastly, we're going to transition into a conversation about specialization around patient populations and conditions specifically. Dr. Seth Feuerstein, founder and CEO of We Health, Colleen Neiswitz, CEO of Groups Recover Together, and Mike Suiters, co-founder and CEO of Positive Development. I will mention as a caveat, 3 of the founders on today's panel are Flare Capital portfolio company CEOs. We wish we were investors in all the companies on the panel today, and they're all passionate, mission-driven founders working on some of the same solutions. And you just want to call out that we have a relationship with 3 of them, and hopefully someday we'll have a relationship with all of them in this company or the next potentially. So moving on, I think the first transition or the first conversation we're going to have is with Dr. Gary Gottlieb. So without further ado, thrilled to welcome him to the stage to have a one-on-one conversation with him. Hey, Gary.
Hey, Vic. Thanks so much for having me.
Thanks so much for joining us. Before we jump in, you have an illustrious career in healthcare broadly, especially in behavioral health. Can you give us a minute or two on your background for the audience?
Sure. I'm a psychiatrist. I'm actually a geriatric psychiatrist. Have provided care and helped to develop programs and systems for caring for people in late life with depression, psychoses associated with late life, and Alzheimer's disease, in addition to administering psychiatric programs. I was the executive vice chair and interim chair of psychiatry at the University of Pennsylvania Health System, while also being the associate dean for managed care there. Then was recruited to Boston to be the chair of psychiatry for the then Partners Healthcare System. Spent some period of that time also as the interim president of McLean, and then became the president of Brigham and Women's Hospital, and then the CEO of Partners, now the Mass General Brigham Healthcare System. Left there in 2015 to become the CEO of Partners in Health, the global health organization that Paul Farmer, Jim Kim, and Philly Dahl founded.
And Gary, if you don't mind,
Sure.
I think the audio is a little quiet. If you could speak a little closer, thank you.
And became the CEO there. Around that time, had the privilege of becoming an executive partner at Flair Capital Partners.
Awesome. Yeah, and we're lucky to have you. In our country, we have a long list of challenges that, for one reason or another, seem to be more difficult in behavioral health than in other areas. Access, the stigmatization issue that is more prominent, I think, in the behavioral health healthcare world, and also the lack of specificity in how we pay for some of these clinical services. Can you give the audience a little bit of a history lesson on how we got here, in your opinion?
Sure, Vic. I think that the issue of stigma has been extraordinarily important and pervasive, both in societies from both religious and social perspective, and in almost all arenas and globally. The notion that people who have suffered with mental illness are not suffering with something that's either volitional, that they could in fact affect themselves, that they shouldn't be able to pull themselves up by their bootstraps. And that's to some extent been reinforced by a lack of biomarkers, a lack of specific ways of identifying those disorders the way we have for some medical disorders, and to some extent by the field itself, because we haven't been specific enough in defining the differences among the different disorders that we have, and also separating what's medical, biomedical, or psychiatric from terms in the vernacular. Being depressed is not necessarily suffering a major depressive disorder, or having anxiety, which may be normative in certain circumstances, isn't necessarily the same as having severe and crippling anxiety or panic. And our inability to do that, and to some extent, the diminution of people who suffer with such symptoms has been very difficult in people having a voice to be able to protect mental illness, to be able to speak for it in policy as well as at employment levels, where speaking about one's illness can in fact seem to threaten one's employment base and one's career. So that's affected overall policymakers in their advocacy for mental health. And for a long period of time, for basically a century and a half, we put people and took them out of society. We separated them from society in a silo, or then in state institutions when they suffered mental illness, without any sense that people could improve over an extended period of time. That changed to some extent in the Kennedy administration, where there was both because of his personal experience and his family, as well as the notion that state hospitals were associated with pretty bad outcomes, with creating policies to try to move mental health into the community and its treatment into community mental health centers, as well as into the general population overall. But the underfunding of the community mental health system, as well as protections that we created, even in insurance as we created Medicare, from paying for psychiatric illness, became problematic. And to some extent, that's a burden that the field had as well, because not only were we not specific enough on the diagnostic side, but the treatments themselves were not associated with an evidence base. So the psychotherapies that were available were not associated with measurement to show the differences that they could create over time, or evidence that they could create improvement. And at the same time, we expected payment for those. So from the perspective of insurance, it was almost a moral hazard that people wouldn't use the insurance if they could, in fact had it. And that caused what felt like just expansive costs. And when commercial insurance created a set of premiums and created policies where they said, okay, you have a 30 or 60-day benefit, as providers, we ended up again killing the goose that laid the golden egg by the mean and the mode length of stay was whatever the benefit was. And this created a tremendous backlash in the early 1990s at the time of commercial managed care, when very opaque and intense processes of prior authorization and carving the mental health benefit came from the commercial and other public benefits, and created significant barriers to access, which created excess capacity and downward pressure on costs, which created really difficult pricing for providers of all disciplines.
Yeah, and I heard a lot there. So I heard a lot about kind of structural challenges, regulatory challenges. And I guess so my question is really, what solutions or what options do we have in front of us if we're going to tackle regulatory issues or structural delivery issues or payment issues? Do we have to make trade-offs in your opinion? Are there any areas that you would focus on?
I think, first of all, I think we do have to make some trade-offs. I think we have to assume and understand that everybody has a brain. Everybody lives in this society. And therefore, if we're going to essentially create coverage as well as policies that care for people we should care for their mental illnesses, their substance use problems in the context of their medical problems. And as we balance payment for a variety of other medical disorders, we understand that a substantial component of premium is going to be necessary to have a labor force that's superb, that is able to, in fact, pay for the education that's necessary and have the expectation of having income associated with it. And at the same time, create ways of creating solutions that are considerably more efficient. And the walk towards value-based payment, in which there's also some sharing of risk on the provider side, creates an opportunity to see where some of that risk that sits in behavioral health can also be mitigated by more appropriate and effective treatments, and where the treatments can be delivered more efficiently, whether that's using a variety of digital processes, using data that are considerably more effective, doing some of it virtually, and additionally understanding the problems of specific populations, so we don't just have basically a big garbage bag of treatments and a big admixture of different problems, but we become more specific in that regard.
Awesome. And I know we have about a minute left. So I want to ask one last question here, and it's about what gets you most excited. So clearly there's a lot of areas for improvement. There's a lot of founders working on different challenges on the panel today, but what gets you excited about the future of behavioral health?
When I see passionate and brilliant people like those people you have in the panel today, trying to use that passion to find solutions around the problems that specific populations have, we have the opportunity to redefine the pathway of solving these problems and staying away from traditional approaches which seem completely inaccessible, impenetrable from the perspective of patients and their families, and that don't focus on primary, secondary, and tertiary prevention. So that if we can get upstream from where people are suffering those problems and reduce them overall, we can identify them as rapidly as possible in the most specific way, have measurement-based therapies that can both be provided in person, but also using digital and other approaches, and have data that then informs how we provide that care. I think we'll be in a much, much better place. And that's part of my excitement about what people hear about today.
Awesome. I couldn't think of a better person to kick us off today. So really appreciate you spending some time with us, and happy to welcome my colleague Ian Chang to the stage, who's going to kick off our next panel. Thanks, Geary.
Thank you so much, Vic. And thank you so much, Dr. Gottlieb. That's super helpful insights. And we're excited to welcome some of our panelists. So while we give folks a few seconds to join, great. Welcome, Summer, Sandra, Tav, and thank you so much for joining us today. I would like to kick us off with a few questions. And given that we only have 15 minutes, maybe what we'll ask you is for you to also introduce yourself and the company you work for as you're answering some of these questions. And maybe I'll start, Summer, given your background both as a serial entrepreneur and also working at some of the largest behavioral health companies, is access the first order problem in healthcare, behavioral healthcare today, or are we shifting to be focused on quality networks and ROI?
Thank you for having me, Ian, and everyone at Flare. My name is Samer Malik. I lead a company called Firsthand, focused in on delivering better outcomes for individuals struggling with serious mental illness. Before this, I was at Optum Behavioral, and before that had launched a telepsychiatry business that Optum acquired. To answer your question, Ian, I think it depends on what position you are in. So if you're an innovator, if you're a business builder, now is the time to start building towards quality and outcomes. But if you are a patient, if you are a payer, we're still on the first order problem of access. And why? Because we haven't moved the needle in big ways on the big things. What are the big things? One is demand. Destigmatization, as Geary was mentioning earlier, and then COVID have driven up demand materially over the past couple of years for mental health services writ large. And yet, in spite of that, we haven't really addressed the supply constraints in meaningful ways, which could be done by either adding more providers to our pool. These are slow coming, but initiatives are underway. Or helping providers practice more top of license or be more efficient. Again, innovation is happening in this space. Lots of the panelists here are moving the needle in that direction. So change is happening on the access side of things, but today it's still a massive problem that needs to be addressed. As an innovator, I think about the chapter to come on the other side of that, which is outcomes. As the innovators today start addressing the access problems, now is the time to start building for scale towards outcomes generation to welcome that next chapter to come.
That's great. Thank you so much, Summer. Maybe just on this same question, Taff, do you agree, disagree, given what things you're seeing from Humana?
Yeah, I think the point of it depends where you sit, I think was very salient. As a payer and a Medicare predominant payer, probably our first, second, and third challenge right now is access to care and getting folks into the care that we already know that they need. What we've found through a lot of the work that we've been doing is that there just simply are not enough providers. And in particular, there are not enough insurance participating providers to deliver all of the care that we know that our members already need. Just to get a little specific, we found that a large percentage of our members that we already know have a significant behavioral health challenge are getting their medication management from their primary care provider. And it's pushing those primary care providers to practice outside their comfort zone. And so we really need to find ways to get our members into the behavioral health specialist care that they need to get to to make sure that the treatment is optimized. I would also say that I don't want to skip over the importance of getting into measurement-based care, evidence-based care, and eventually return on investment, because that's really going to help grease the wheels of really getting to that next level with access as it relates to payers. So I don't want to minimize it, but certainly from the payer side of things, access to care is the biggest issue right now.
That's great. And Taff, we'll come back to the measurement-based care point shortly. But maybe Sandra, love for you to introduce yourself, given that you have been consulting, but now also working for a while, the innovator to address many of these problems.
Thank you. Yes, I am a licensed clinical social worker and by training, but have spent most of my career in the consulting industry, the last 10 years, really working with large employers on designing their mental health programs, and more recently joining Headspace Health, which is, of course, the combination of Headspace and Ginger. And what I think is a really powerful part about the two organizations coming together is that it provides a way to really get people into affordable care. So expands access through leveraging that sort of the digital component, coaching, and then, of course, access to therapy and psychiatry. So it's a really powerful combination of the two that I do think will impact access in a positive way. I agree with the other panelists that access is still very much an issue. We've heard from both of them about the shortage of therapists and the need to build the pool, which will, of course, take some time. I think that where the access also needs to really be directed is around getting people to the right type of care. An individual who's suffering probably doesn't have a lot of information about all the different options or the different ways that they can receive support and treatment. And we don't do a great job for the most part as a market in helping to diagnose and assess and get the people to that very right part. With Ginger's coaching, we do a lot of work to leverage that coaching experience and help people in a sort of a wide net sort of basis, and then funnel them to the resources they need. And there are other vendors in the market doing very much the same. I think that over time, quality and outcomes will be the area that gets more focus. but short-term access is definitely still needs to be addressed.
Thank you so much, Sandra. So maybe let us go back to the quality point, but all of you have mentioned the importance of quality. Maybe Taft, to start with you, are we really measuring quality from the payer or employer standpoint, and what's on the shortcomings?
I think as an industry, we're just scratching the surface of quality. We are starting to see some organizations really delving into, I think, different types of measurement-based care where they're really looking at actual clinical outcomes and the type of treatment being provided, but that's not the norm yet. Most of what we find when we are doing quality type measurements is really, we're still really following process measures. And so it's things like, can you get somebody in quickly after they've been discharged from the hospital? That has nothing to do with the actual quality of the care being delivered or the appropriateness of the care being delivered. It's just, do you have an empty slot in your schedule that you can put a patient into? And so I think over time, we're going to see much more innovation around making that measurement easy and making adhering to evidence-based practice easy and demonstrable. I think Geary made the point of we haven't had a lot of that in behavioral health. And I think it's been to the detriment of progressing into value-based care and value-based contracting because it's been so much based on this individual. Everybody's treatment is different. You can't measure the outcomes. And so we were stuck with kind of units of service. And that's really what the orientation has been for quite some time.
That's super insightful. And maybe going back to you, Sandra, do you see something similar on the employer side?
Yeah, absolutely. There's been much of a great increase of interest in what solutions, what vendor programs can really impact the overall well-being of their population. The challenge is that, as was mentioned, there hasn't been a lot of standards or a streamlined way to measure care, especially in the outpatient environment, where most people will come into contact with care. Higher levels of care, I think, over time have collected metrics and measures to report out on. But in outpatient, it just hasn't happened. And a lot of people don't even realize that. I honestly didn't realize it until I started practicing privately as a therapist, that no one was really measuring, no one was really monitoring. So that's something that I've carried with me as I've worked with employers and really trying to emphasize that the solutions they look at should have at least a set of measures that organization is using to be able to report back, not how timely care is necessarily, although that is still important, but whether the care is making a difference.
That's great. And maybe Summer, love to get your perspective, and given your various companies, how are you measuring qualities like today or going forward?
Yeah, Taft hit the nail on the head just a moment ago. We are still at the earliest chapters of introducing process measures with some uniformity across the provider landscape. It will take some time for those measures to truly become the norm and for payers and providers to have the right exchanges around this. Innovators are helping make that happen. But where we want to go is beyond the process measures to true clinical and cost of care measures. One of the big barriers to actually achieving this oftentimes is unifying the risk. Geary mentioned this earlier, that we carved out mental health a few decades ago, and only now are we starting to recognize that needs to be undone for certain cohorts, and that we really need to unify the risk dollar around the individual. And it's only when you start to unify the risk dollar that you can start to accurately measure the depth of a clinical intervention. When you start getting the folks on the right psychotropic medications, how does that then impact their medical costs and conditions and vice versa? And so part of the effort here is unifying the risk dollar between behavioral and medical, and then using that as a platform to really start diving into clinical measures and cost of care measures that really can't be dealt on an individual basis. So that's what we're trying to do at Firsthand, is unify the risk and look at cost of care and clinical measures beyond process measures to determine the impact on the individuals that we are serving.
Absolutely. Thank you, Summer, Sandra, and Taft. I know we can continue this conversation for hours, and maybe before we wrap up this session, just want to quickly go around the horn. Of course, many of our audience are curious to hear your point of view on how access to behavioral care has changed over the course of last 2 years due to COVID. So can you talk about virtual? Is it here to stay, or are we going back to in-person visits, and specifically for those services that require prescribing? Maybe I'll start with you, Sandra.
Sure. Yeah, I think that virtual care came to its own during the course of the last couple of years. I do think that there still will be a role for face-to-face care as we go forward. And clinically, there are some situations in which face-to-face care is really the treatment that's called for. But I think that virtual has shaped the way that we do expect to receive services. So it'll be a mix, but definitely face-to-face is here to stay.
Great. Summer, you agree?
Yeah, the data here is interesting. So February 2020, about 2% of all services, behavioral services in this country were delivered via behavioral health, right? So the month before COVID. April 2020, that number was up to about 74, 75%. And the remaining in-person were mostly inpatient and residential services, right? So we went from 2% to 74% due to COVID. The last data I saw suggested we were somewhere close to 24, 25% of all behavioral health services in this country are now delivered virtually. The question is, one, what is the run rate under current technology and products that are out there? And then what can technology and product innovation do to move that number north? We now have evidence that you could go as high as 70%, but right now our run rate suggests we're in the 20s. So that's a call to innovators and technologists to figure out what's missing and how do we make technology and service delivery and the products accessible, easy enough to use, and covered well enough to get to more digital and virtual first presentation.
That's great. And Taff, I know we're coming up on time. Anything you would like to add? What are you seeing from Humana?
Yeah, and our experience is very consistent with that. And just to say that I think COVID made people try an experience that they didn't think that they would like. And a large portion of them found out that they really did appreciate the convenience of being able to just go ahead, log on at the appointment time, do their appointment, and as soon as they log off, they're back into their lives. And so I think continuing along that patient experience journey and really improving that experience and working out some of the kinks with difficulty of logging on and using the technology will push that current 24, 25% continually upward. I do think that there's a lot of room for virtual, especially in behavioral health going forward.
Thank you so much. Thank you to all of you, and thank you for your time and wisdom. We're so refreshed and encouraged to hear innovators like you driving our behavioral healthcare forward. And maybe for now, I will pause and then we'll continue the conversation. For now, I would like to hand over to my colleague, Bill, for our next panel on designing solutions for teens and adolescents. Here you go, Bill.
Excellent. Thank you so much, Ian. Really appreciate it. Great panel, super insightful. And I'm just beyond thrilled to invite our next panelists up to the stage. Naomi, great to see you. Thank you for joining us. Lynn, great seeing you. Thank you. And Nikki, of course, awesome to be with you. Teens and adolescents is an area that I'm really passionate about in terms of their behavioral health, but I think no one more so than the three of you. I really believe you're the three best CEOs in behavioral health, full stop. And each of your companies is focused on teens, which is essentially an epidemic level. I was looking at a CDC report that got released just a couple of months ago, and two things just stuck out for me for maybe a little bit of context for this panel on teen mental health. One is that 40% of teens said they experience depression, and 20% of teens said they're dealing with suicidal thoughts. And so in the face of that epidemic, and Naomi, maybe I'll kick things off with you, what is it about the behavioral health needs of teens that requires its own unique solution?
Thanks, Bill, for the question, and thank you for Flair for hosting this important webinar. So I think a few things I'll point out. First of all, great to be here. I'm the CEO of a company called Brightline. We're the first nationally scaled pediatric mental health solution. So we support families with kids as young as 1.5 years up to age 18. And I think what's important is to point out that, yes, we're here and talking about the youth and teen mental health crisis, but as a reminder, 40% of all severe mental illness occurs before the age of 14. And so I think as a country, we really need to start to identify programs and resources for children, even much younger than teens, and waiting, I think, until the adolescent teen years has been problematic for us as a country. But specific to the adolescent and teen needs, I think what we know to be true from science is adolescents and teens really benefit from having a dyadic model. That means that you're providing services directly to the youth, but also engaging parents and caregivers along the journey. And that's a very complex model to deliver in terms of structuring the pathways to engage parents and caregivers at appropriate times while still giving that adolescent and youth autonomy. And so there's a lot of complexity there. I think the other piece that's pretty unique is the programming and the types of programs that adolescents and teens need are very different than adult programs. And so, for example, at Brightline, we obviously build all of our care delivery around cognitive behavioral therapy and other proven evidence-based protocols. But specifically for adolescents and teens, we nuance the program. For example, we have an anxiety program that's specifically for youth that are exploring their gender identity and have anxiety around how to come out to family or caregivers or friends. And so it's not just a general anxiety program, it's an anxiety program geared towards the types of things that youth and adolescents may be specifically facing as challenges. I think the other piece that's really interesting is we find that we have to architect a very different data and privacy model, and that the state-by-state regulations vary in terms of how you handle the privacy and data for an adolescent or teen. And so you have to be able to essentially really navigate state-specific requirements for when does that adolescent or teen have the ability to have their own therapy session, their chat with their own coach, their own information around prescriptions, et cetera. That may be a very different model than what we have in the adult space, where you're essentially not having to deal with that level of complexity. So there's a whole bunch of reasons why I think we're seeing an increase in needs for resources that are specific to the pediatric population, adolescents, teens, but also obviously much younger patients as well.
Yeah, no, that's great, Naomi. That's a great response. I also should thank you too for serving on the board of one of our investments, Bright Health Group. So a shout out to you for all the work you're doing there. Nikki, maybe a similar question back to you and all the work you're doing at BME Health. And again, feel free similarly to talk about BME Health in your response. But what is it about teens from your perspective that demands such a unique solution? And how do you ensure it's an authentic and genuine experience for the teens that you're helping?
Yeah, great question, Bill. Such a pleasure to be with you and Naomi and Lynn. I'm so happy to be here. One thing we've learned, if anything, it's that teens are not just little adults, right? They deserve a solution built just for them. And we're building just that. Nikki Tesler, I'm CEO and co-founder of BME Health, and we're really combining engaging technology and human touch so that we can transform the teen mental health space. And an important, unique piece is this generation. They're digital first. They're the most diverse generation we've ever known. And so it requires all of us to rethink mental health design for this population. And so static mental health care just doesn't work. The support needs continuous intervention and always on, always available, lower cost resource. And I think most mental health apps, unfortunately, today have either not been grounded in science or they're designed for adults first. And so I think exactly what we're trying to do at BME is create an app that provides that support that's familiar and it's fun and it's authentic, designed for how teens want to communicate, but it's vetted in behavioral health experts in teens. So think of it evidence-based medicine in groups of honey, if you will. So thanks for having me today.
No, that's great. And Lynn, maybe next kind of over to you. We all talk about product market fit and so many other segments of health tech. How do you know in this behavioral health segment for teens when you have product market fit? How have you thought about it in your company?
Yeah, thank you for having me. I'm Lynn Hamilton. I'm the CEO of Vita Health and have been working in mental health care in a couple of different legs of the stool for 12 plus years. And so at Vita Healthcare, we recognized that suicide, along with other mental health conditions, is really reaching an epidemic level in the teen and adolescent market. And so using science-based published approaches to develop our continuum of care. And when we think about our end customer, which is the teen and adolescent, we do also think about the family support system, but as importantly, what is the voice of our customers saying? And so having that feedback from the population is very important, and we take that feedback to inform our next iteration of the product. We also are very intent on measuring the outcomes, and outcomes can take many different flavors in terms of length of engagement, which it may not need to be 2 months or 8 months. There may be something in between, and it's a very personal decision for each patient in terms of where they are on their journey to wellness. So tracking clinical outcomes, getting the voice of the customer, and really developing products that are cognizant of the environment that teens and adolescents operate in. So when you look at the rise of the mental health concerns right now for teens and adolescents, it traces back very directly to social media. And so how do we take social media and use it for good in helping treat this population and in meeting them where they are and understanding how those triggers affect them and how that is different from serving an adult population?
That's great. And you touched on social media, so important. And maybe Nikki, back to you, because I would like to get your perspective on, is social media being demonized? Is it at the root? Can we use it for good? How can it help? And so would love your thoughts about social media in particular.
Yeah, so I think we have to be very mindful of social media and some of the impact. That said, the fact that they're digital natives really requires us to think strategically about understanding that this digital first generation is not going away. Social media and their understanding of connection is here to stay. And so we can either, and I'm a parent, I can either move away and be fearful or lean into and really look at it. And so one of the things at BME Health, for example, is that we're trying to build an app that's familiar to them and fun. And so social media can look a lot like that and authentic, but the difference is we've got to figure out how to avoid the pitfalls and the harms of these types of platforms that are designed for teens and aren't vetted by mental health experts. And so the idea of having youth technology experts, having mental health clinicians, all a part of it, so that we can really go after this in a comprehensive and prudent way. Because what we know about Gen Z, Bill, is that Gen Alpha is next, and Gen Alpha is even more Gen Z than Gen Z. So we've got to figure this out together.
No, that's a great perspective and a great clinical model. Naomi, quick question for you. If you could move one metric or advance one thing in teen mental health, what would that one thing be?
Yeah, I think it's a really important societal shift for us to essentially be normalizing and destigmatizing teen mental health. And so I think the one metric would be just the very long lag time from the moment where a youth identifies that they may have something going on or that there's a need for additional resources to them actually getting appropriate support and resources, whether that's, and part of that answer is built on the notion that we need to be much more expansive, not just in terms of affordability and destigmatization, but in terms of the types of access. And so it's creating avenues systemically for us to have more peer supports, more coaching supports running on evidence-based protocols, obviously more access to therapy, inclusive of virtual therapy. And so I think it's that time frame around early intervention and meeting the child before they become an adolescent or teen, meeting the child where they are so that we have a greater likelihood of success with an earlier intervention.
Oh, that's great. Such an important discussion we're having on that point in particular. Lynn, quick question for you. What's the optimal role of families and schools in this teen mental health crisis?
Yeah, it's a really important part of someone's wellness journey. So school, of course, where a teen and adolescent theoretically is a significant part of any given year. And so understanding both the supports that are there as well as the triggers that are there, right? So we understand that during school, there is a higher likely incidence of students coming to us for care because those triggers of being in that social environment are heightened. At the same time, school support resources can also be very beneficial in both supporting the teen and also helping direct them to care. So I think the school has a very important role to play on both sides of the equation. Likewise, the parent or family support group is also really critical. One of our programs does work with just the support of adults in a teen's life. And the feedback that we've received and from those adults about how helpful it has been for them to understand communication techniques and how to understand the challenges that the teen is facing has been resounding and very positive. And so we know that working with the family support is very critical in the wellness journey of the teen and adolescent.
That's great. And maybe just in our final minute, Nikki, I'll look to you. Naomi mentioned privacy and the important role of privacy, of course. And how do you think about that private relationship with the teen members at BME Health? How do you preserve it while at the same time, how do you ensure that the right care is being delivered?
Yeah, great question. And it's funny, all of our content and language and use on our website and socials were created with our teen advisory board. And so privacy and everything that comes with it includes over 80 teens right now who are helping to basically design this app and believe in and enjoy all of that. And so in addition to the great team of teams we have, this teen advisory board has really kept us honest about the importance of privacy. And so what we've done is ensured that the youth technology experts and the mental health clinicians have that content is appropriate. And even we've signed up a chief youth officer to ensure that message is safe so that privacy can be maintained in all levels, because that trumps everything.
That's great. So fantastic being with each of you. And again, the work that you're doing is just so critical, so important and needed. And so we all thank you for it. And thank you for being with us this afternoon. Before I turn it over to my partner, Dan, just a quick shout out to a PBS documentary that started airing last night called Hiding in Plain Sight about teen mental health. Part 2 is this evening. And so for those of you interested in this area, feel free to watch it real time. It's pretty powerful, I think. Thank you again for the great work each of you is doing and appreciate you being with us. And now, Dan, I'll turn it over to you.
Thanks so much, Bill. Excited to introduce our next set of speakers for the anchor leg of our session today, and we'll be on specialization in behavioral health. We'll invite Colleen Neiswitz, CEO of Groups Recover Together, CEO of WeHealth, and Mike Suiters, CEO of Positive Development. We've got about 15 minutes for this section. We'll point questions to individual panelists, but want to do our best to foster a conversation. So feel free to chime in. I will play time cop. We're seeing a rise of specialization in behavioral health, from SUD care, autism care, serious mental illness, eating disorders, OCD, the list goes on. If phase 1 of next gen behavioral health was digital access to behavioral health, phase 2 is a deep dive into conditions that drive medical spend and suffering for millions of patients across the country. So excited to have our panelists discuss this topic. Colleen, I'll start with you. Groups is focused on patients dealing with substance use disorder. Why does the behavioral health landscape need specialized services that focus on one or a few conditions at a time? And can these specialized conditions serve as a node or a central condition and then serve as the quarterback of care for all mental and physical health? And please do talk a little bit more about what you do at Groups and a little bit more of your background as well.
Sure. Thanks, Dan. Hi, everybody. Thanks so much for having me. I'm Colleen Neiswitz. I'm the CEO of Groups. And at Groups, we think about your question around specialized services being necessary largely because for us, people who are battling substance use disorder as a primary diagnosis for what they're working with us on, it is the reason to engage and the driver of engagement with both us as a treatment provider, but also in many cases for the underserved populations that we are serving, it's the driver of engagement with the healthcare system more broadly. So from our vantage point, without addressing these conditions directly, the other mental and physical needs will actually go unaddressed, which benefits nobody. At Groups, the reason why we feel like the specialization is necessary is because we believe really strongly that both community and trust are both a huge factor in the treatment success of somebody who's battling substance use disorder. And without a specialized service offering that really has those core values in every part of the treatment life cycle, we think that the ability to manage this chronic disease that is addiction is a lot harder. The trust that our community builds helps us actually become the quarterback of care. Oftentimes at Groups, we're providing outpatient treatment for substance use disorder, and over 70% of our volume today are Medicaid beneficiaries. So we're really focused on an underserved population. And the trust and community that we build really actually help us become the quarterback of care, because usually when folks engage in treatment with us, their distrust of the healthcare system is at its highest. And what we actually do, among many other things, is help them engage in the broader healthcare system in a healthier way than they have in the past. So things like where they used to potentially show up at the emergency department and other very costly and not that effective interventions, we are focused on helping them re-engage with the healthcare system by finding a primary care provider, by finding mental health support. But we build that trust through the community of our treatment model.
Yeah, no, it's so powerful, Colleen. I heard you mention super important themes, the fact that you're serving an underserved population, the fact that these are chronic diseases, right? There is no cure. These are longitudinal management issues, building community and the need for navigation and trust. So all super, super important. And that this central condition can be the access point with which they access the entire healthcare system. You know, one of the things that you also mentioned is kind of reimbursement and the coverage around Medicaid and the limitations and the opportunity that provides. Seth, I may transition over to you. You are the CEO of We Health, and full disclosure, it's a Flare Capital portfolio company, and you develop digital first kind of care models for patients struggling with often overlooked behavioral health conditions. And oftentimes one of the reasons why these conditions have been overlooked is due to the reimbursement system. So would love for you to talk a little bit more around reimbursement for specialty BH care models, some of the challenges and some of the opportunities that you're seeing in your work at We Health.
Thanks, Dan. Thanks for having me. I know many of the people on this group, so it's good to see you again, or for the first time, but I didn't know you. I think the issues are multiple. I think one of the issues, and I'll just say it out loud, is that mental health parity law is violated pretty broadly in our healthcare system. I think it's pretty well publicized that the feds have not gone after it and states have not gone after it aggressively, but that sounds like it's changing. So part of it is getting comfortable discussing that sometimes with payers. Part of it is which conditions you target. It can really depend. I think that Taft spoke about value in certain interesting ways. There's measurement-based care is one phrase, outcome-based care is another. They're related but distinct. And behavior, I often, when I talk to payers, I spend a lot of time on suicide interventions as well as some other diseases. I try to use models of cardiology and oncology in the discussions because behavioral health, by the way, payers aren't the only ones creating problems. Even our clinical communities, I'm a psychiatrist by background, have done a very bad job advocating for our professions and what we do, and helping the payers understand what's prevention, like in cardiology, what's intervention, what's deadly, what is the different value across that continuum? Because right now there's generally a single code for a single time stamp on what you're doing, or a single location like inpatient versus outpatient. And that's actually a disservice to the payer, it's a disservice to the provider, and it's a disservice to the patient, unless you're only taking very unsick people and treating them a lot, in which case it's great for you as a provider, but bad for everyone else. That's what the payers are trying to protect against. I would say if you want to contract with them, where we've seen successes with data, and where, you know, ultimately people are going to have to go is potentially being more aggressive, right? Sometimes payers don't do the right thing and it's not intentional. It's just institutional from such a long period of carve out and a certain mentality on cost reduction. I think we're going to start to see those transitions. Taft discussed it, right? Like the PHQ-9 or PHQ-8, if you're afraid to find out if someone's suicidal, which is an example of the bias in the ecosystem. Not asking about suicidality would be like an oncology clinic or a payer saying, we only want benign cancer patients. That's just absurd, right? Like death is part of healthcare, death is part of psychiatry, and we need to understand and distinguish and differentiate those, and value needs to be attributed to those. And that's really an outcome. But if you're using something like the PHQ-9, that's really more measurement than outcome. Real psychiatry, if you were going to do an analogy with oncology or cardiology, needs real outcome measures with specific attributable outcomes. And that's what payers I've found need to see and want to see, but it requires buy-in from a lot of stakeholders at a payer. And it's happening. It's going to be a process. And Sandra talked about it as well early on. I don't know, does that answer your question, Dan?
It does, Seth. Again, you brought up a lot of just super important points. A couple of things that I heard you mention is just the importance of advocacy, right? When dealing with reimbursers and payers. Again, I can say this because I used to work at a payer before Flare Capital. The payers tend to have all the money, but sometimes they don't have all the information. Oftentimes you have millions of data points, millions of claims that you just don't have the time to go deep into each of those areas. And companies focus on some of these issues can bring that information to the table, and payers, it's super important for them to look at data, look at outcomes. The other thing I heard you mention, which again is super powerful, is that maybe in our industry, we're looking at cosmetic metrics, cosmetic outcomes, and not the hard facts. And so again, this is something we all have to chase. Yeah, please go ahead.
One more, I'll give an example. Like in Lynn's case, she has published data that she can reduce suicide attempts by half. Payers pay for that if you have the data. And so I think that it's one thing to say you read a book and you're doing an evidence-based program. It's another thing to show that the team did the study and showed it reduces death. That's a very powerful metric, and one that payers often do, but not always. But if they're not, they should pay for. But I think we don't talk enough about that, and it's important.
Yeah, no, super powerful. It's a perfect transition to Mike. Mike, Positive Development is pioneering a more comprehensive care model for patients and families managing autism spectrum disorders. Would love for you to kind of introduce your company, talk a little bit more about your experience in engaging with these patients, their families, and then all of the other stakeholders, all of the other caregivers that are providing care to what is a high needs population. And you should also touch on kind of what Seth had talked about, outcomes, barriers to reimbursement care. So Mike, turn it to you.
Great. Thank you so much for having me, Dan. Such a great group of folks to participate with, such an important set of topics. I'm Mike Suiters. I'm co-founder and CEO of Positive Development. We are a provider, as Dan mentioned, of whole person, but really whole family developmental therapies with a focus on serving the neurodiverse population, and especially those on the autism spectrum, which represent more than 1 in 44 children today, as estimated by the CDC. So our approach is a bit different. It's an alternative to the status quo behavioral or ABA approaches that folks might be familiar with and that are largely covered today. From a health systems perspective, we're really focused on helping our payer partners put a meaningful dent in the access challenge by covering our model, and in so doing, bringing a net new supply of historically underfunded therapies in network, and doing so with superior outcomes and 25 to 50% lower costs, with the end benefit that we can ultimately serve more families and deliver better outcomes for the same per capita cost. So to that end, when we think about engagement, it really starts with understanding the objective at hand. So in our case, our North Star is to deliver industry-leading outcomes as efficiently as possible. So the second thing we do is then think about who are the stakeholders that we're really trying to engage, and what are the most effective modes of engagement to get to those outcomes. And so in our case, again, we're an inclusive whole family approach to treatment, which means we work directly with a pediatric population. But as Naomi mentioned, the dyad is really important. We're just as focused on parent and caregiver education and coaching. It's absolutely fundamental to our models. We really have 2 sets of stakeholders to engage. For those pediatric clients, most of them are preschool and elementary school aged and filled with energy, often bouncing off the walls. And so when we're working with those kinds of folks, attention spans and tolerances for boredom are pretty low. And so it's really important that therapy be fun and engaging. And so our approach really harnesses that energy. So our approach is fun, it's physical, it's dynamic, and as a result, engaging, and largely in person, really as a modality. In addition, a trusting and safe child-therapist relationship is absolutely critical to success. And in-person interaction is the most clinically and cost-effective way for us to develop those bonds. In particular, when you think about our population, many of our clients have more limited or no language available to communicate. And so in-person is the best modality to be able to form those bonds and connections. On the other hand, for caregivers, for parents, virtual care has, for us, really shown to be a very effective and convenient mode of delivery, mostly because it is convenient. And so it increases follow through and engagement, which ultimately drives outcomes for us. But also, look, getting coached to interact with your child can sometimes feel awkward. And so Often the screens helps reduce some of that looking over the shoulder feeling that can ultimately help parents get comfortable and relax, which makes them more engaged and effective as part of our care team ultimately. So that's how we work directly with our clients and our families. When we think about engaging the rest of the ecosystem, for us, it really starts complete with data and outcomes measurement. So can we capture the right data to educate the other stakeholders, whether they be pediatricians, schools, care managers? What is the individual profile of the client, and where and how are we building the capacities that support development? And because our space has been so lacking in data and transparency, stakeholders are just thrilled with what we're able to share, which honestly is pretty basic relative to basically any other part of healthcare. As an example, just last week, we had a meeting with one of our major referral partners, a children's hospital, and we were able to review cases with real outcomes data and demonstrate progress. And that meeting ended with a giant group hug and tears of joy, which is the kind of stakeholder engagement that's possible when you combine superb therapy with empirical outcomes data.
Super powerful, Mike. Unfortunately, we are at time. Mike, Colleen, Seth, thank you so much for all the important work that you're doing. I will kick it off to Vic to close us off. Thank you all.
Can I say one last thing? It was great to see 3 women CEOs on the last panel, second panel. So just FYI.
Agree with that. And just some housekeeping to close it out. Thank you to all the panelists, all the guests today. I think it's inspiring to learn from them and know what we're working on in this space. And hopefully it inspires the rest of us to spend a little bit more time and effort in behavioral health. If you have any questions or want to continue the conversation, please feel free to reach out to us. We'd love to do that. So thanks so much and have a great rest of your day.